Great pleasure this afternoon to introduce Dr. Jeremy Boal to you for our Health Policy and Management rounds this afternoon. Dr. Jeremy Boal is President of Mount Sinai Downtown and Executive Vice President and Chief Clinical Officer of the Mount Sinai Health System. He is responsible for overseeing the creation and implementation of the Mount Sinai Health System's more than $500 million investment to create Mount Sinai Downtown, which includes a new Mount Sinai Beth Israel and an enhanced New York Eye and Ear Infirmary of Mount Sinai. In his role as System Chief Clinical Officer, Dr. Boal will partner with the Chief Medical Officer, Dr. Vicki Lopachin, to ensure the highest level of quality, safety, and service for patients. Dr. Boal received his bachelor's from McGill University and his medical degree from the Medical College of Wisconsin. Please give a welcome to Dr. Boal.
Well, thank you very much for that warm welcome, and thank you for coming out this evening so that we can spend a little bit of time together. It is a real honor to be here. I don't do this very often. I don't accept many invitations to speak because we're, as you can imagine, very busy, like everybody in healthcare right now. But this was an offer I couldn't refuse. It's a tremendous honor to be here. By way of background, I will tell you I am a geriatrician, and before I was in healthcare administration, I spent most of my career, clinical career, doing house calls, working in a home-based primary care program that's called Mount Sinai Visiting Doctors Program. And I started it with some colleagues back in the 90s because we recognized there was this very large gap in services for people who they might just live a couple blocks from a hospital, but they couldn't really access services in a consistent way because of the combination of their illness and their social situation and housing and all the like and all the other things that we struggle with in New York. So all those years of doing that gave me some insight into just how hard it is to knit together a system that works for real people and not just for kind of folks that can easily access services and have everything going for them. And I've tried to carry that with me all throughout the rest of my career in healthcare administration and quality and safety. I was asked to talk about the implications of the Mount Sinai-Continuum merger, specifically with regard to population health and outcomes. And I'm going to broaden the topic just a little bit. I will focus on this, but I do want to talk a little bit about the implications of this merger more broadly. And I want to spend quite a bit of time actually talking about sort of the whole healthcare landscape that we find ourselves in. I don't have any disclosures in terms of consulting fees or anything else. I want to talk to you about the Mount Sinai Health System and a little bit about the local and national context for healthcare. A little bit about what we consider key components of health system redesign are in today's day and age, which is, I think, very different than it was just a few years ago. And then walk you through an example, one example of what health system redesign we think should look like now, and then open it up for questions. I'm hoping that we can have a really constructive dialogue, and what I talk about today, some of the information you'll see, you'll probably say, I know that already. Other things may be new. Some things you may not agree with, and that's okay. I'm hoping we can, like I said, we can have a conversation about those things. So just to start with what Mount Sinai is. Mount Sinai Health System came together in October of 2013. The Mount Sinai and the Mount Sinai School of Medicine and a very small hospital called Mount Sinai Queens was one entity, and the Continuum Health System was another entity. The Continuum Health System had basically 5 campuses, hospital campuses, sitting on 3 licenses and a vast ambulatory network. And those 2 entities came together in October of 2013 to create what we now call the Mount Sinai Health System. And it's a pretty big system as systems go, although certainly not the biggest. There are about 2,500 employed physicians and about another 1,200 that are in our clinically integrated network. We have about 300 ambulatory locations throughout the region. So we're much more than just a hospital system. We've got the 7 hospital campuses. 5 of those are on the island of Manhattan, 1 in Brooklyn, 1 in Queens. Number of surgery centers. And we've got this School of Medicine, the Icahn School of Medicine at Mount Sinai. And this is just a map showing you where our locations are. The magenta circles are our hospitals. All those dots are ambulatory sites. And we also have a number of ambulatory sites out on Long Island as well. So a couple of years ago, we put this ad in the New York Times Magazine. It says, if our beds are filled, it means we've failed. And for most people who are familiar with the healthcare industry and familiar with old Mount Sinai, this was a bit of a shock. The model of healthcare for most large health systems, certainly in our region until recently, was mostly around trying to bring as much volume into hospitals. And if you're going to bring volume in, you want it, if possible, to be high margin volume. You know, we used to joke in healthcare that CEOs had three questions they always asked themselves, hospital CEOs. Are my surgeons happy? Are my surgeons happy? And are my surgeons happy? The idea was that you know, this was a fee-for-service environment, and everything we built was important, but what really mattered was, were we bringing high complexity, high margin cases into our facilities? You know, that has never been the sole mission of Mount Sinai. For those of you who know Mount Sinai, it was founded a long time ago with a much broader mission with regard to serving everybody, service of ability to pay. Beth Israel had a very similar background and a similar set of values. So their value system, I think, had a lot wrapped in it that was more than just about fee-for-service medicine. But the environment that all health systems were functioning in just 10 years ago was almost exclusively geared around fee-for-service payment. And most healthcare economists will tell you that what you incent for is what you get. And our health system largely developed into one that was built that way. This ad was an opportunity for us to tell the world and tell ourselves, which is just as important, that that wasn't good enough anymore. And that even in a place like New York that had always resisted change, that we had to embrace it, and we had to try to move the market toward something that made more sense, something that where there was more alignment between how we get paid and what actually is right for our patients and our communities. And we felt very strongly about it. We felt strongly enough to actually announce it to the world. We didn't consider it a strategic hedge that we would just invest a few dollars in, and just in case the world flips to value. We actually felt that we needed to move the market to value. And so that's what we've been focused on now for a number of years. And I'm going to walk you through sort of how we do that work and why we're focused on that. So what does our landscape look like, our local landscape look like while we're doing this work, and why are we focused on it? So you're all seeing, all of us, these traditional health systems change right now. We're acquiring other hospitals. There's a tremendous amount of consolidation nationally, and certainly in our market as well. I'm sorry. The screen here just is doing loop-de-loops. Oh, yeah. We forgot to mention that. Really, it's okay. If it's doing that, I can read off here, so it's all right. Oh, it'll stop. Okay, good. It's not me, though. I'm okay. All right. Just making sure. So systems are also acquiring lots of doctor practices now as well, and some are experimenting with owning their own insurance companies. And we'll talk a little bit more about that as well. Physician groups are getting larger as well. A number have sold to outside investors. Most are pursuing some path to value at various paces, so they're also trying to contract for something along the road to risk. And many are launching what are called wraparound IPAs, or basically they're partnering with independent physicians as well and forming these much larger groups in addition to just having a large employed group. We've seen a massive rise in urgent care, and we'll spend a little bit of time on why that is and what the implications are for that. And then there's a whole host of other structures of primary care that are developing as well. There's a tremendous amount of experimentation that's going on in our market and others. Organizations like One Medical and Boal, all sorts of different kinds of independent physician groups. Payers are now getting into the physician space as well and buying groups. And there's a large growth in the penetration of worksite clinics. And you know, again, that's a really interesting phenomenon that we're seeing, and one that I think is quite healthy that we can talk about as well. What's happening on the health plan side? Well, we know that in our market, it's actually more fragmented than many markets. There are still quite a few commercial insurers here. Unlike some markets that are down to really one or two, Anthem, United, Aetna, Cigna, and Emblem are all sort of splitting a lot of the commercial market here. There's a low Medicare Advantage penetration in the core of the city, excluding dual eligibles, but it's higher in the outer boroughs and the counties. The individual market is dominated by managed Medicaid payers right now, Health First, Fidelis, MetroPlus, Affinity, some new entrants, Oscar, Care Connect, which recently announced that they were actually going to close shop, but Oscar is still here. And we're finding a very high receptivity, but low experience in risk-based models. So almost every payer in the market is interested in doing this work. Some are more capable than others because it's tricky. It's very tricky to adjudicate and to administer these value-based and risk-based models. It's not something that you can turn on overnight, whether you're a plan or a provider. What does all this mean for the Mount Sinai system and for what we're trying to create? So we think that there are two strategies that we have to pursue. The strategy over here on your right is to be the specialty and acute care provider of choice for all population health managers. And you could argue that that's what we've been doing all along. And that is, whatever the payer is, if you're a managed care company or if you're an employer or a union, if you have members who need complex care, we want you to choose us because we want to produce the best outcomes at the best price. And that's mission critical. What we've added to that is we also want to be the most effective population health manager ourselves for the lives that we are taking risk on and for our value-based contract. And it turns out that if you do this one really well, it helps you do that one well in addition. It's not enough to do this, but it creates a platform for you to do both. And we think both are important for a host of reasons. In this market and in a number of other markets, both of these missions are really important. And one of the biggest challenges that organizations face, and I'll talk about in a little bit, is actually how to do both those things, because they're not always completely aligned. A caveat: we tend to overestimate the amount of change in 3 years and vastly underestimate it in 10. So a lot of what I'm going to talk about, is sort of directional, but I can't really tell you what the health system is going to look like in 10 years. 10 years ago, I couldn't tell you what it would look like now. And I think that's just something we all have to recognize, that there are disruptors, mostly for the good, that can change things really, really rapidly. And we've seen some of them. Urgent care was an example of that. Amazon, threatening to enter the PBM space is another example of that. There's multiple examples of that. Okay, let me talk about the changing landscape. So, and a lot of this, I suspect this is where you'll say, oh, we know most of this. So we know that the demand for services is increasing in this country. The population is aging. We don't have the healthiest population. We know that there's general medical inflation, and we know that medical technology, pharmaceuticals, and the like are driving an increase in expense, in cost per capita. We also know that the funds available are not increasing. We're already spending more as a percentage of GDP than any other nation. We know that for decades there's been a cost shift to commercial plans because health systems have basically said, we can't support ourselves on Medicaid and Medicare, and so we need the commercial plans to pick up a larger percentage of the increase than they would otherwise. All that just gets passed down to members and to employees, and that's unsustainable as well. We know what's going on with Medicare. We know what's happening with Medicaid as well. And we know what's happening with the taxpayer base. And all of these things are going to challenge our ability to find the dollars to continue to support the existing system the way it is. So fee-for-service providers like us are caught in this reimbursement compression. And we're in the middle of this mutually assured destruction, fighting denials. And for those of you who are familiar at all with what's going on in hospitals and healthcare now, hospitals are hiring armies of people to fight denials for payment, and insurance companies are hiring armies of people to I guess, deny. I don't want to say deny. I guess that's the wrong word, but to present their view of what's appropriate to cover. And we're just increasing our staffing and our technology to convince each other that we're doing the right thing. All of those dollars are away from the bedside, all of them. And in a room, we'd all say, this is crazy. Like, this model is not helping anybody, but we don't have a choice. Neither one of us has a choice in the traditional fee-for-service environment. So that's a challenge, and we're starting to see narrow networking, or organizations being narrow networked out based on price. So that's a lot of what I think is happening on the fee-for-service side. Population health presents a potential opportunity because it creates an environment where you get potentially much more alignment between how payment is made and where risk is borne and who's actually delivering the care. And so many of us feel pretty strongly about the need to move toward a population health framework in partnership with our payers. It's not easy. It's incredibly difficult, and it's very hard to move from one to the other, as most of you are familiar with. But we do think that it's the right direction to move in. Again, most of you know this already. There is financial risk shifting from the payer side to the provider side at varying rates. And again, we think this can be a very healthy process if it's done right. Our system has chosen to not actually have our own insurance license. We have a partnering strategy with our payers, and we have found that to be much more viable because a lot of managing risk is something we just don't know how to do. We're simply incompetent at doing it, and it's something that payers have done. That's a core business that payers have done. What we do is we deliver care. So if we can knit these pieces together the right way, we think we can deliver a lot of value. Population health works. I think that's been asked and answered. When it's organized the right way, when there is alignment between how we're paid and how the patients are chosen and the care models that are delivered, we collectively can produce better outcomes. These are just 3 examples. Dramatic reductions in medical loss ratio, lower expenses, better outcomes, higher satisfaction, and the like. That doesn't mean that you can just rinse and repeat, and this will work everywhere in every environment. But I think we have to accept the fact that population health is not some weird pipe dream that academics invented, but that can't work in the real world. I do have some obligatory demographic slides, and I apologize for these. But I think it's important that we just, at least all are on the same page. We know the population's aging. And we know that's going to drive a lot of demand for use. We also know that it's a relatively small percentage of the population that accounts for a lot of cost in the system. Not much disagreement. What's less well known is that there's different clusters of high-cost patients. It's not all one bucket, and on the provider side, that's not really well known. And so many times people will try to develop one solution for something that is actually many different problems, and that's something that we have to recognize and be comfortable with. So just as an example, over here on the outpatient side, end-of-life costs, complex chronic disease, cancer and autoimmune diseases. Over here, traumatic events, very high hospital costs, what we call frequent flyers, substance abuse, mental illness, unstable housing, and the like. These are not all the same condition and not all the same problem. The other thing that's not as well known is that from one year to the next, it's very difficult to predict who's going to be in that high-cost bucket. It's easy for us to imagine that you can isolate a cohort of people and predict that they're going to be high cost and manage them, in a continuity model. But in many cases, people drop in and out of being high cost, and that also creates a level of complexity that we have to get our arms around. Okay, we have healthcare economists in the audience, right? A few, one, others. Okay, so I have spoken to many healthcare economists, and most tell me that when we say a third of healthcare spend is non-value added, that's an underestimation. What's your take? Hard to measure. It's probably why there's no solid number. Yeah. Right. That's absolutely true. And one person's waste is another person's value, depending on how you define it. Peter Orzag, who's on our board, he thinks that it's closer to 50%. And again, it's very hard to, yeah. 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 Yeah, I think that's absolutely correct. And then the question is how much is necessary. But I think that's very true. And so, go ahead, I'm sorry.
And it is also problematic, too, that administrative costs get bundled with overhead. Mm-hmm. So basically it becomes harder to discern, like, okay, even if you're paying more for administration to have a better flow of care and services, then that still is considered part of the overhead, which you want to theoretically reduce as much as you can. Mm-hmm. So how do you find the balance?
Absolutely. And so what I'll posit here is that while we don't know what the exact figure is, I suspect that, well, we agree that there is some degree of waste in the system. I happen to think it's ginormous. Being in the system and seeing what goes on and seeing the variation in care, yeah. So, I would say that there's probably there's some significant value in there, and there's probably some things that aren't value added. And I don't know how to pick it apart, but I think it's somewhere in there. But I don't think that's where most of it is. My bias is, and it's a bias, that most of it is the stroke of the pen that physicians use. It's how we behave. It's the tests we order. It's the specialty consults that we provide. It's the overuse, the overtreatment, the overadmission, and the like. And the reason I believe that's the case is because there's this unbelievable variation that you can't explain based on the condition of the patient. You just can't. And so it looks like if we cleaned all that up, there'd be a lot of excess dollars around for us to use. Okay. We also know hospital use is declining dramatically. And in New York, just as an example, we've had 19 hospital closures since 2000. These are the hospitals that have closed since then. And in the last 5 years, just based on bed days, another 500, the equivalent of a 500-bed hospital has closed every year in New York City for the last 5 years, just based on how many fewer patients are needing a hospital and shortening length of stay and everything else. So that's a dramatic shift, and it's continuing. And by the way, we don't know if that's going to accelerate or taper off. There's a possibility that this country will need half as many beds as they have today, 10 years from now. And I'll talk about why that's possible, or even less. We know that consumers are voting with their feet. So we create a health system, we organize it a certain way, and then, but consumers, they have potentially a different set of needs and expectations than what we've built for them. So that's where urgent care comes in. There was really no urgent care not that long ago. We had primary care, and we had specialty care, and we had EDs, and we had inpatient care. And now, 1 in 4 Americans uses urgent care. The vast majority of people who use it don't use it for an emergency. Only 3% of people who go to an urgent care center need to be referred for an emergency. They go for what we used to think people would either go to the primary care doctor for, or would just stay home for. It's a lot of colds and flus and sprains and strains and stuff like that. The traditional healthcare system completely missed the boat on all this. Why? Because we didn't create access. So in New York City, where we have probably more doctors than we need, by a lot, most people, when they try to get in to see a doctor, are told there's a 2 to 3 week wait. It makes no sense. And if you have an urgent issue, when you need to see a doctor, you can't. But you can get an appointment in 3 weeks to see a doctor for preventative care. It makes no sense. So, of course, market entrants will figure that out, and they have figured that out. And there's all sorts of implications for this and a number of other models. What about the cost side? So in today's high-deductible world, when the first dollar is coming out of the patient's pocket, people are still showing up at emergency departments with strep throat. And they're walking out with a massive out-of-pocket payment. And they're showing up at urgent care with that, and that's almost the same as a physician visit. Massive difference, same level of care. Some would argue that actually this is worse care because you're probably going to get over-tested, and you're going to pay more. And that's just built into the system. So when we talk about waste, it's hard to not imagine how much opportunity there is. Again, consumers are voting with their feet. You're familiar with One Medical? Primary care practice, started in the West Coast, it's now on the East Coast. They're growing by leaps and bounds. Their big innovation to have access to your medical practice through the phone and through email and through telehealth, in addition to office-based visits, being able to schedule same-day appointments. Stuff the industry should have solved 30 years ago. But that's what they did. It's not that complicated. Okay. So with that as background, I want to talk to you a little bit about sort of what we view as key components of system redesign and why we are reorganizing ourselves so aggressively as a health system. And so I'm going to march through these relatively quickly, and then we'll get on to just one quick example of what we think true redesign looks like. So the first thing is, it's absolutely critical that we reorganize ourselves into high-volume centers of excellence for all complex care. That should be non-negotiable. There's more than enough evidence that if you're getting a complex procedure, if you're having your liver resected, if you're getting a lung transplant, if you're having cardiac surgery, high-volume centers do it better than low-volume centers. And that makes intuitive sense. The teams that are doing that work, they've seen every complication. They work really well together. You can afford to have the best equipment because you're doing it in volume. This should be, we should accept nothing less than that. And so a big part of the work that we're doing in this system is actually to take all of these assets, these hospitals, and think about, what does a high-volume center of excellence look like? And how do we do the painful work of getting physicians and staff to move to new facilities and work in new environments so that we can make sure that we're guaranteeing the public the best possible outcome? It's very hard. It's not easy. We get that. There's politics, there's union issues, there's all sorts of things, but they're all surmountable, all of them. And so rather than having 3 cardiac surgery programs, a moderate volume one down here at Beth Israel, a moderate volume one at St. Luke's, and a high volume one at Mount Sinai Hospital, we now have 2. We have a high volume program here, and we have a high volume program here. We could not justify running 3 programs, 2 at volumes that made it essentially impossible for us to guarantee the kind of outcomes that we needed to guarantee. Neurosurgery, the same thing. We've now moved neurosurgery to 2 hospitals instead of 4. When we became a system, you could get a complex hepatic resection in 4 of our hospitals. You can now get it in 2. It's the same idea. I think this is something we have to commit to. Because it may not be in the short term, it certainly isn't fiscally prudent. In the long term, we hope it is. And it doesn't necessarily please everybody in New York that we're trying to keep. And New York is a highly competitive environment. And one of the reasons that we don't make these decisions is everybody's worried that they're going to lose their talent to another facility. But at some point, we have to just sort of say, there are certain standards that we have to adhere to. And I think this is one of them. Complex care needs to occur in high-volume centers of excellence. The second thing is we've got to transform care models to lower cost and to improve outcomes and satisfaction. This is not us. This is actually NYU, and I'm incredibly proud of what they did there. Michael Burke found walking increasingly painful last year. Crossing the street and tying his shoes became challenges, and colleagues noticed he was limping at work. On a recent morning, Mr. Burke reported to the Hospital for Joint Diseases, part of NYU Langone Medical Center in New York City, for hip replacement surgery. The surgeon had promised him a better quality of life and said both the operation and recovery would be quick. About an hour later, he was out of surgery. By 4 p.m. that afternoon, he was upstairs in a ward, walking on crutches, down the hall and going up and down a small model staircase. At 6 p.m., he left the hospital and headed home with his wife to northern New Jersey, where he had a bowl of chicken soup. Just think about that. 10 years ago, 5 years ago, unheard of. And still the vast majority of patients, when they get hip replacement, are in the hospital for multiple days. And in many cases, it's appropriate to stay. You have to be very healthy to go home the same day, and not everybody's that healthy. Many still go to subacute rehab. Some go to acute rehab. This is a miracle compared to where we were just 10 years ago. So imagine that kind of innovation happening in all our disciplines and all of our service lines. That's what's going on right now. And that's why, and that's the kind of, in my opinion, that's the kind of approach that adds value to the system. It's lower cost to whoever's paying for care, higher satisfaction, and over time, many of these have demonstrated better outcomes. A big one, drive out non-value added variation. We have to get really serious about this. And I'm just going to give you an example, but this is one of an infinite number of examples. This is variation in the care for routine low back pain at Mount Sinai. these are all practices here in our health system. And these are all the patient counts who presented with low back pain. And this is the number of referrals, or patients who were sent for referrals, the percent of referrals, who got radiology imaging and who got opioid prescriptions. There's zero correlation here with the status of the patient. There's a very high correlation with how those physicians trained, what they were taught, and the practice environment they come from in their specialty. We don't know. We actually don't know. But what we do know is that it's a little bit like rolling dice. The door you walk in our health system, determines the care you get when you're practicing like this. And that tells us that there's waste. There's an opportunity to get this right. That doesn't mean that there's one right way. But when we bring all these physicians together and our analysts and others together, and we look at the data, the evidence, not just our own data, but what does the evidence tell us about what's proper care, we can actually develop a set of approaches that are rational, that lower the total cost of care and produce more consistent outcomes, and measure and study and improve. This is the variation in referrals to various sites from those practice locations. Another example, spending on post-acute care has skyrocketed. It's more than doubled in the last decade. And I think many of us would like to imagine that that's great, right? Because, care is moving out of the hospital. But the reality is there's just as much variability that we can't explain by the status of the patient in the subacute and post-acute realm as there is anywhere else. This is an example of that. Post-acute care monthly adjusted differences, this is across hospital referral regions. It's all over the map. Some of the biggest correlates of how much post-acute care occurs in the market is the number of post-acute facilities. Just like the number of hospital beds frequently determines the admission rate. It's not necessarily driven by the needs of the patient. So if we look at this with a critical eye, we realize there's a lot of opportunity. Number 4, we have to make it easy as PI to access primary and immediate care. We talked about urgent care. That the triage point for what drives a lot of cost is primary and immediate care. And if we're really good about getting patients in quickly, and that quickly doesn't necessarily mean they have to come take a half day off from work and go to the office. It could be a televisit. It could be something online. But if we can manage the triage point better, then we have a better chance of directing the care where it makes sense, where it's appropriate from a cost and quality standpoint. This is just an example. We launched request to same-day appointment for the downtown market this year across all specialties. Not easy, again, not normative for our market, and we're now rolling this out to the system, and we're going to layer on top of this a telehealth opportunity as well. Now, again, should we have done this 30 years ago? Of course we should have. This is not rocket science. The only business we're in is taking care of patients. This should be normative in our industry. Building a robust product and contracting strategy. I won't spend a ton of time on this, but if we're committed to value, it means we actually have to act that way. We can't just keep signing fee-for-service contracts and demanding rate increases and saying we're all about value. So thanks to Health First and a number of our other partners, we've had incredibly robust and constructive dialogue with payers around a path toward full risk. And it's a path. It takes work and it's hard to get there. I won't go through all of this, but there's really 2 parts to this. One is getting paid for value and the other is using value to capture lives. So whether it's across commercial, Medicare, or Medicaid, there are opportunities to design a contracting strategies that incent the right set of behaviors, that create an organization where we spend a lot more of our time worrying about keeping people well, rather than waiting for them to get sick and come use our high-cost, high-margin services. And that's what this is really all about. And it's about creating that pathway, because we have to learn how to do it. We don't know how to do it out of the gate, and our payer partners have to learn how to do it with us. And this is just at Mount Sinai an example of where we're headed. This is sort of our growth in lives that we're managing under some kind of value-based contract. A lot of this is shared savings right now, but over time, what you'll see is the light blue is what's fee-for-service with sort of pay-for-performance opportunities. What's in pink, magenta are shared savings lives. And then what's in darker blue are full risk lives. And you can see over time as we get into 18 and 19, a larger and larger percentage move into shared savings and full risk. Now, that doesn't mean that we stop delivering fee-for-service. We still have a very large fee-for-service business as well, because remember, we want to be the provider of choice for everybody else who's managing population. But these are the folks that we're managing ourselves. Number 6, we could do a whole hour on this, but we had to build and focus analytic and care management resources, and this is very expensive. And again, this is one of the reasons that we've partnered with our payers rather than competing, because a lot of this they do much better than us, and we've worked hard to figure out what makes sense for us to do and what makes sense for our payer partners to do. But to date, we've spent over $100 million on building this infrastructure. Over 350 people, FTEs, dedicated to practice transformation, analytics, managed care contracting, and care management. It's a huge part of our business now. And that means that we had to make choices about what not to spend on. And I think that's important. If we treat this like a strategic hedge and make a small investment, we're never going to make the transformation. If we burn the boats and commit to this and agree that we're not going to spend money in other areas, then we have to make it work. And I think that's our hope. And you can see a lot of the spend is on care management resources, both in practices as well as centralized resources, and an awful lot on data tools and IT support and analytics and the like. And the last one is to carefully titrate this financial and clinical transformation. And the reason that this is so important is it's very, very easy to get into trouble trying to make this transformation. This is clinical transformation and financial transformation on the two axes. If we were to move to more of a risk model without actually clinically transforming and still being a system that is in the old fee-for-service model where there's probably considerable non-value-added variation, we would run out of money really fast because we'd be taking risk on all these patients that we wouldn't be able to manage. We wouldn't have the capability to manage those patients and keep them well at a lower cost. On the other hand, if we transform like crazy and develop the optimal clinical model where we're doing everything right and keeping populations healthy and out of the hospital and as well as possible on a fee-for-service basis, all the benefits, all the financial benefits accrue to others, and we would run out of money to be able to run our operations. So we have to stay in this middle area, and it's not easy. We have to actually sort of wobble a little bit as we move from a fee-for-service environment to a risk environment. And we have to do both things at the same time. We have to learn how to manage patients while we're contracting differently. And that's where we are right now. We're on this path doing that work with our partners. Okay, I want to just briefly close on one particular hospital just to give you a sense of how this sort of all comes together. And so when we talk about our hospitals are full, it means we've failed. When we talk about the opportunity to drive waste out of the system and the risk to not, if we don't evolve, I want to talk about the model of hospital at home. So about 25 years ago, Johns Hopkins started experimenting with a model of care called hospital at home. And they got some grant funding. They were learning from a number of other countries that had been experimenting with this model. And the idea was to carefully select cohorts of patients who came to an emergency room with an acute illness who met criteria for inpatient admission. So these are sick patients. And develop a hospital-level care model at home and offer those patients the ability to go straight home from the emergency room. And they published their studies, and what they showed was that they were able to reduce the total cost of care, improve outcomes, improve safety, improve patient satisfaction. But there was no way to pay for it because, the incentives just weren't aligned. There was no payment structure for hospital at home. A number of years ago, working with colleagues at Hopkins, we applied for a CMMI grant for about $10 million to actually scale up that hospital at home model. And we did that at Mount Sinai. And what we found was very similar results to other studies. We saw a massive reduction in the length of stay on the acute phase, a massive reduction in readmission to the acute phase. So these patients were getting better and they weren't then getting sick again and needing to be readmitted. Higher patient satisfaction, lower complication rates, and 93% of the patients were able to complete the whole thing at home. So consistent with other findings. And during that time, a number of other health systems, they've also been experimenting with this model, trying to figure out how to pay for it. It's easier when you're full risk, when you've got, first dollar. It's almost impossible on fee-for-service. So we thought for a long time about, what do we do with this information that we have now? We know this works. We know it's the right thing. We have the content expertise now to roll this out more broadly. So a couple of things. One is we're clearly working at the federal level, and we testified with a number of colleagues at PTAC, which is this committee that advises the Secretary of HHS on new programs, and on this program. And they actually sent their recommendations to the HHS that this program should be implemented into the standard Medicare program. Not as a pilot, not as a demonstration, but it should just be implemented into the program, because they felt it was that effective in producing better outcomes at the right price. And so who knows where that'll go. Do we even have a Secretary of HHS yet? Still waiting, right? So we'll see where that ends. But we've spoken with all these colleagues in the commercial payers, Medicare Advantage space, Medicaid, Health First colleagues, and we've found a tremendous amount of interest in doing this, because if you're a payer, this is just fantastic. If your member can get better care at a lower overall price, what a great differentiator. So we partnered with a company called Contessa, because we can't administer these claims. It's not a skill set we have. And we're working with all these partners now to roll this out more broadly. The model is very simple, and I'll just walk you through it. A patient shows up at one of our emergency departments. They meet criteria for hospital at home. They meet criteria for admission, and they're a subset that meets criteria for hospital at home. We offer them hospital at home, and I'll walk you through what that looks like. About 70 to 80% of patients who are offered that choose it. 20%, 30% say they'd rather be in the hospital, and that's fine. Nobody ever gets forced into this model. We also have another arm that's really rehab at home. So these are people who have come into the hospital who normally would go to a subacute facility, but we think we can probably manage them at home with enhanced resources. These are the kinds of conditions that we can treat in this model. So you've got, things like COPD, CHF, pneumonia, UTI, cellulitis, and the like. On the surgical side, we're doing a lot of work right now around post-surgical at home. Not surgical at home. We're not doing the knee replacements at home. It kind of smells like it might happen one day, but this is really to get people out much faster and get them into an environment where they can be safer, frankly, than in a rehab facility or a hospital. In the home, we send in all the necessary services: physicians, nurses, infusion therapy, labs, radiology, and the like. Over time, there'll be technological monitoring that goes in and the like, but I would encourage you not to think about all those technologies as solutions. They augment a clinical model. They don't really replace a clinical model. And then patients stay in that until they're stabilized, then they enter into a post-acute phase. And then we continue to manage them and monitor them for 30 days. It's a 30-day bundle. On the rehab side, it's a 60-day bundle. And we're accountable for the total cost of care. And basically this is the model for how we make sure that the right patients are getting into the system. There are clinical exclusion criteria, there are Millman criteria for inpatient admission, and there's an authorization process that the payer makes sure that we adhere to. Basically the way the funding works is there's an episodic payment from the payer. Thank you. And the TPA, that the third-party administrator, administers the fee-for-service payments for all the components, and then there's shared savings at the end for if there's money left over. So here it is. Here's the kind of the economic model. So somebody gets all of these services in the course of a normal admission, and historically the payer has paid $11,500 for all that. We offer a price of $10,000, so it's a 15% discount. And then in that delivery of care in the home, and for those 30 days, those funds get parceled out on a fee-for-service basis to the providers. And at the end, in this particular case, the episode cost a little over $7,000. There was a little under $3,000 savings, and the savings to the provider that accrued then to the provider were about $1,500. So economically, it works. We think it works for the patients. And so this is an example, again, of how do we really drive value in an environment where we've got to figure out how to do much more with less money, because a lot more people are going to need care. And like I said, there's not more money coming into the system. And how do we do it in a way that doesn't bankrupt us as we go through this process? Not easy, right? Getting the hospital delivered at home is not easy. This is not one of our doctors. This is actually just a delivery person in New York. But it's just a reminder that this transformation work is really hard. It's so much easier just to sit back in the hospital and make things a little different and hope that it'll all work out. But that's really not what society needs. And in the end of the day, I don't think it's healthy for health systems to think that way. We're going to have to do things that are really, really hard. When we introduced same-day access, it was not easy to convince our practices to change the way that they schedule. They already feel like they're incredibly busy. But we don't have a choice. We have to evolve. And building hospital at home, all these types of models, I think we have to accept the fact that we just have to do it. And struggle through this so that we can get to a better place. That's it. That's all I had. I'm happy to answer questions, field oppositional viewpoints, anything you guys want to talk about. Yeah. I think there's a mic behind you.
Hi.
Thanks.
I'm really interested in.
I'll be with you in a moment.
Mike's here.
Go ahead.
Go ahead, Jennifer.
Hi. No, I'm just kidding. I study implementation science, and I'm really interested in how you talked about transforming the whole shebang here. Can you talk a little bit about how you or others at Mount Sinai work with your staff and work with the physicians about making these changes? Because I find that a lot of providers are kind of allergic to, especially non-physicians, are allergic to conversations about money.
Yeah, it's a great question. So I think it actually gets at the heart of this, which is whole system change, and most of us, folks who don't come from an implement science background, we bring a whole bunch of assumptions in about how people change, and they're all wrong, and we usually learn the hard way, and that's for most of us that's the case. We've had the opportunity both at North Shore LIJ and here to partner with folks who really treat this like a science to learn about whole system change, and we've also borrowed a lot from other industries, not just healthcare. Whether it's Rickover and the nuclear navy, or industries that have been able to evolve, or parts of industries that have been able to evolve faster than other parts. We've gained a series of insights that we're working to use as drivers for change. So some of them, just as examples, we cannot create the kind of change we need in rigid hierarchies, period. And in traditional models. They just will not ever work. And so this idea that we can maintain our traditional departmental structure and our traditional tables of organization and implore everybody to work differently is a fiction. And so that's a really big one. What goes along with that is this idea of teamwork and flattening the hierarchy. And you know this because you study it and you live it. It's until we create an environment where the folks at the front lines who actually know what's going on, have as loud a voice, if not louder, as the people who are in the C-suite, who by definition have no idea what's going on. They can't. And create an environment where you have that dynamic interchange of ideas and a willingness to take risks. It's also impossible to drive the kind of change that we need to drive. So a lot of my time and a lot of my colleagues' time are spent on those things, and actually trying to change the structure and the culture of the organization. One thing that we're going to go through this year, actually, along those lines, is we're actually working through a massive effort to reset our culture as an organization, not by creating a set of values and emailing them out, which is not uncommon and works as well as any other email that goes out, but actually by bringing together everybody in the organization, all 36,000 employees, all the thousands of physicians in very small groups with no hierarchy. So it's the neurosurgeon sitting next to the environmental services staff, sitting next to the person from legal, and doing intense work together about, what is it, what are we here for? and what does the ideal state look like? And what's it going to take for us to get there? And we've learned from a couple of other organizations that unless we do that, we really are, it's going to be hard for us to change that environment. It's not going to come out of, the rapid change isn't going to come from the top. I'm convinced of that. You're welcome to. We'd love to have the help. Thank you. Yeah.
So this is sort of a tangential question. Maybe it's not fair to ask, and a simple "I have no idea" is acceptable. I just wonder if you think there's still a place for primary care physicians to continue independently in independent practices.
I think there's absolutely a place for independent primary care physicians, and that's one of the reasons that we actually, rather than just pursuing an employed physician model, we actually built a clinically integrated network. Clinically integrated networks they're a complicated legal entity. They're the only way that we have to actually partner with independent physicians to share quality data and contract together. And the legal foundation for it is, and it allows us to avoid antitrust, the legal foundation for it is that we have to use it to drive performance. We have to use it to actually study our performance and get better. And that by doing that, and it's incredibly rigorous, like what you have to build from a legal and operational standpoint is incredibly rigorous. What it allows us to do is to bring exceptional primary care physicians who are, in solo practice or in small practice into this world, and it allows them to get better contracts so that they can stay independent. My hope is that through mechanisms like that, we'll always have a strong, independent work cohort of physicians. That being said, there's a lot of things moving in the other direction, and we know a lot of physicians have just, basically ran for cover of an employed group, and so we're trying to create the flexibility to do both.
George Hulse from Health First. So I liked your health care at home. We're trying to experiment at Health First, and we're going to expand it, I think, as a result of this presentation. What we'd like to do, we'd like to find those people who have not come in for key examinations, and when we do things in the community, we'll take out a van and we'll do those examinations in the van. So breast cancer screenings, we can do having cardiologists come out and we can do EKGs, we can do dental things in the van. And so the idea of, we want to do it in the home, but we're going to do it in the home neighborhood. And from what you said, I see we've got a lot more need of that so that we can get these screenings. Rather than go to the hospital or to the doctor, we'll take the screeners to them.
I got to congratulate you on that and so many other things that Health First does innovatively. We partner on a whole bunch of things. A lot of the stuff I was presenting today, we do actually, the first time we do it, we go to Health First and say, what do you think? And every time Health First says, yeah, let's try that. That's another great example of just doing it differently. And a lot of the folks that need us the most and need you the most, they're not going to come in. We need to go to them. So I think that's fantastic.
Thanks. It was great to hear some of the innovative things that, momentum for change that's happening. I was wondering, to what extent do you guys engage with the target population of patients around these models and make sure that it's really reflective of what they, it sounds like it is. It sounds great to have someone come to my house and help me instead of going all 5 different places around town. But how do you get input from the consumers that is, not just a few vocal consumers, but, representative, systematically collected information that will, better help you match what you're trying to do with what they actually want?
It's a great question. I don't think we do enough of it. We're better in some areas. So, for example, at hospital at home, we had the good fortune of having almost 15 years of experience doing home-based primary care. And we had massive cohorts of patients who had, conditions that, in the absence of this, had to go into the hospital. And we learned a lot from them about, what they wanted and what was so dangerous about being in the hospital and the transition back home and everything else. And that gave us a lot of the intestinal fortitude to push that model. And without that, I don't think we would have really known what was needed and whether it was that important. In other areas, we're trying to do a better job, actually, of using our community needs assessments to actually drive program change and program development. I think, historically hospitals have done community needs assessments, and it's sat over here in sort of like the government relations part of the organization. We're trying to bring it into the strategy part of the organization. And so, for example, downtown, we're doing a lot of that. And we, rather than doing a traditional community needs assessment, we brought in an outside firm and we ran a lot more focus groups and a lot more polling. And it's generating tremendous insights for us into what we need to do differently and better. And an example of that is meeting the needs of the disabled, which we just weren't doing enough of. And I think we can do a lot better on. But I think there's a lot more room for us to do that kind of work. Where we don't do enough of it is around specific diseases. In pockets we do. So I can tell you for our CF program, I know that we do. But I think there's a lot of other opportunities.
Yeah, I mean, where I was coming from with the question was from a population-based perspective, where we really do try to often do things at scale that are, that we think are better for the population, and often the ideas come from ourselves and our experience, and we think they're good,
right.
And a lot of people engage in them. But I guess my point in asking the question is, like, what you really want is not just a decent amount of engagement in what you're trying to do, but you want as full engagement as possible. And you also alluded to, I think, an important issue, which is that there's a lot of heterogeneity in what people want and need, by disease, of course, but maybe by other factors, like as how much coverage they have, or things like that. So it's great that you're thinking about it.
Yeah, no, I think you're right, and it's not. There's a lot more opportunity to take that information and really use it to drive how we organize ourselves. Our community needs assessments are all public documents, and the one we're working on for downtown now is almost finished, and it's much richer than the ones I'm used to seeing. So, I'd encourage you guys to take a look at that and see if it's useful to you as well.
This may be a bit early to ask a question, but let me try. Given what's happening with tax reform, especially with the exemption or the preclusion of state and city taxes in the federal proposal that's moving forward, and the implications for that, specifically for states like New York, which use those taxes to create a safety net, right, and a very generous Medicaid program. Smart, have you had any thoughts about what that may mean, especially given folks who are price sensitive may either insist on tax reduction or leave the state, and how that could create a spiral related to our safety net? And yeah.
Yeah, no, I'm glad you raised it, actually, and I think that there's extraordinary risk at the city and state level, and we know that the state is looking probably at a pretty big budget deficit for 18, even before that, and it's hard for me to imagine how it's not going to impact the safety net. It's not going to impact Medicaid. It's not going to impact the other programs that we all rely on, that frankly still aren't as big as they need to be. And we are very worried about it. And an example is when we did this community needs assessment, we do have one of the most generous states in the nation with regard to Medicaid, but there's gaps everywhere. There's still gaps everywhere. New York City, Manhattan we don't even have a medical shelter. And it's something, that a lot of people believe in and we need, but, we haven't figured out how to fund it yet and everything else. Behavioral health is still profoundly underfunded. So to go from where we are now to this other level, I think it's going to be really, really tough. And again, I think it's just another reminder that we have a sort of a responsibility to try to take as much non-value added cost out of the system, so that there's money around that hopefully can be redeployed, to provide value to our patients. I think the work's going to get much, much tougher. I really do.
Yeah, I too am very worried, but I wanted to just give you a shout out because my mom was fortunate enough to participate in the MAC program.
Is that right?
And I only have fantastic things to say. I mean, she had very well coordinated care, nurse practitioner, physical therapy, occupational therapy, nutrition on a regular basis. They were super communicative, not just with her, but with me.
Good.
home phone, cell phone, email. And to Dennis's point, man, when they gave us that assessment questionnaire that I had to sit down with my mom, who's legally blind, to find, to respond to provide feedback on her experiences. As long as that questionnaire was, she was very happy to participate.
Well,
so
thank you.
I'm thrilled to hear that even with all that attention, and the providers were all fantastic, they gave me their personal numbers to call. It was still a significant saving over hospitalization. Yeah. So I'm just expressing both my gratitude and also my fear about the future.
Thank you for saying that. That you trust us with your care and that it went well is the highest compliment. I'm very grateful for that. Thank you.
Thank you for the presentation. I have two questions. So we are at School of Public Health, and I can use we here. We believe public health cannot be discussed without addressing poverty and socioeconomic determinants. And I think because of the geographic position of all the sites, everyone has a comparative advantage and disadvantage. I wonder if we come more while integrating the system, and if we did, then how did you address? And my second question is, I see the trend is the patient care is more getting more patient-centered, while the provider and the payer are held accountable. So I heard you saying there's no other way, we need to evolve. But as a leader of a large provider system, how do you feel about it?
So let me answer the first one first. So those are great questions, and I agree. Again, I think it's very, very hard to solve quote-unquote medical issues in isolation, and it's what we're struggling with. And part of the challenge, again, is as a society, we spend a lot less on social good than most developed countries, and a lot of it ends up looking like medical issues. But it's much more complicated than that. When we came together as a system, very different geography and very different environments. Mount Sinai Hospital has always sat sort of on the border of one of the poorest neighborhoods and one of the wealthiest neighborhoods, and has sort of a mix of both. And there's been a ton of cross-subsidy over years. I think commercial care has helped subsidize a lot of the non-commercial care. Beth Israel, a lot of the commercial base had left the hospital over many years, and it continues to have a very, very high percentage of government payer, and a very aging infrastructure. And that hospital financially was sort of on its last feet. In fact, if it hadn't been acquired in this merger, it would have run out of money last summer, not this past summer, but the summer before. Because the finances had gotten that bad, and some of it was because the payer mix wasn't sustainable for the expense base, and so what we've tried to do is we've tried to think about the whole system as one giant entity and cross-subsidize to the extent that we can, so that we can provide care to all the communities we're responsible for. We also have to make massive investments in transforming care, so that we have a sustainable model. So, for example, downtown, we're in the process of shrinking Beth Israel Hospital as we move to this model where we have these centers of excellence, and building a brand new Beth Israel that's purpose-built kind of for now versus the past, that is much more about high throughput, a much smaller bed tower, but emergency services, behavioral health, the things that the community needs to stay there. Whereas for the really complex stuff, again, we'd have it done in high volume centers of excellence. So, and that's all being funded by Uptown, because downtown we just don't have the money. Every year, last year on an operating basis, Beth Israel lost about $100 million on an operating basis. This year we were budgeted to lose $140 million. We're probably going to come out closer to $120 million. All that is being filled in by Mount Sinai, so that we're not accruing more debt. We're just starting each year sort of at zero. And Sinai is funding the build of the new hospital and the renovation of our other facilities. Some of that we'll get back when we sell the old Beth Israel, but we have to put a lot more money in than equals the sale of the asset. I apologize. Your other question? I'm sorry. Oh, right. So in terms of the patient being the one who can make the decision, but we're the ones who are stuck with the accountability. I think it's great. I think, we have never done enough around patient engagement and behavior change. We just haven't. And we need to. That's part of being a good doctor, I think, or being part of a healthcare system. Provider is attending to motivation. And sometimes you win and sometimes you lose, but I really think, we talk a lot about this idea that the patient has to have, quote unquote, skin in the game. So they have to have an economic responsibility if they're not going to behave the right way. I don't think that's a healthy mindset for a society. I guess I'm being it's a little bit of an editorial. We need to own a lot of that, in my opinion. We've never invested enough energy in patient engagement.
We have time for about one more question for Dr. Boal. Will?
Yes, fantastic presentation. So there was just one particular touch point that was occurring to me, and that is you want people to not use the hospital, but use primary care or an urgent care within the hospital network to have lower costs, like for treating a strep throat or a bad cough. But the problem is that deductibles as a health trend have been on the rise continuously among the insurance companies, and basically those deductibles need to be met in order for any payment to occur by the insurance companies that people can use to put toward the care. So how do you deal with sorting out through that paradox, where basically that you need to have high enough a price range for people to go to the emergency room to meet the deductible just to get access to the general care that they would otherwise really want to have were it not for the deductible in place, but then that would also interact with part of your business that you're trying to have lower costs for those treatments that can be done in a less costlier setting.
So big picture, it is a really good question. I think big picture, we have to grow our market share. There is no model that works without us growing our market share, because we do want to drive down utilization dramatically of high-cost services. And if we do that and we have just as many hospitals and just as many surgeons, then that doesn't work economically. So we have to grow our market share so that lower utilization still fills the assets that are going to continue to generate a return on a fee-for-service basis, and or shrink those assets to the appropriate size. That's kind of the trick of this whole thing. There have to be winners and losers. As you move to value, you've got to actually, we believe we actually have to get bigger in terms of the lives that we're responsible for and the patients that are using our services.
Okay, let's thank Dr. Boal once again.
Thank you. Thank you very much.